So what is your feeling about the high volume patients who have achieved tremendous remission? Should we be considering local therapy in them? Oh, any thoughts, Bob? I mean, there is some evidence that says it helps.
You know, there's some debate. Todd knows this data very well, whether that strictly speaking, primary prostate radiation in all comers decreased future events of toxicity down the road. Now, some of those were triggered by if you did future radiation, that was an event in the trial. But a purist would say you could treat all those patients and decrease the risk of future genital urinary events. So if you have a great response to therapy, although sometimes I get the flip side if people haven't had a great response or that's the only dominant part of their disease, I think the biggest thing is a lot of times patient preference. Are they sort of leaning towards, some want less visits, some of them want more. And then also how well I think they're going to tolerate prostate radiation. If they're up, that's why I can't wait for some of the surgical data. If they're up 8 times a night, urinating, and are, have presented in retention, I'm not super thrilled about delivering the radiation, at least during that time. But if they have no urinary side effects, those guys can get through treatment with low single-digit grade 3 toxicity. And so that's sort of, for the patients that I see, they're selected, I think, to be sort of predisposed to want radiation, but some end up getting it, some don't.
I mean, I feel like that previously these people didn't live long enough to see the effects of, whatever local GU control you're getting for them. Now with better and better treatments, now that they're having this long-term survival, I think adding the local therapy probably makes sense more than before.
Or another scenario I'll see, I've had them with Phil and others, the patient doesn't tolerate systemic therapy for a while, but has done really well for 3 or 4 years and gets reimaged with the PET scan and has a couple of spots. And sent for radiation in that setting too, because the patient wants to sort of delay the reinitiation or change of systemic therapy. And boy, not all of these situations exactly fit into our trial. So.
Yeah, but the recurrent ones, the STOMP trial showed that it's so far equal.
Right. But
the delaying.
Yeah, which is what I use.
The selective patient population.
And isn't in those elected to stop treatment, right?
Yeah, good point.
They had primary treatment and developed metastases.
Yeah.
So
one other point I want to make, what about molecular-only metastases? I know the case I had was bone scan showing 3 mets, but what about, and we frequently see that. Do you intensify treatment, first of all? And how far do you go with that intensification? What do you think, Phil?
To me, it really depends on what the pattern of molecular metastatic disease is. So if you have a case where there may be 1 or 2 pelvic lymph nodes like Bob and Todd were talking about, I may or may not intensify in that case. But if you see a patient who has 10 tiny lesions spread throughout his body and bone lymph nodes, then I probably would treat that as a more traditional metastatic disease. Sometimes we get PET scans that show disease that would probably be detectable on standard imaging, and then I would definitely treat it as a standard metastatic patient.
I do rely on that CT. That's like our poor man's little conventional.
Yeah, the bone, the mid-nose, all that. What do you think, Frank?
Yeah, I think I take a similar approach to Phil, and if it looks like it's a lot of stuff on molecular imaging, I'd treat that similarly to conventional imaging positive and do treatment intensification. Of course, unless they had really high volume, I wouldn't add chemo.
Right.
But maybe the flip side of things, for patients who have very little disease in molecular imaging. Yeah, sometimes I approach those more like a biochemical recurrence patient. Say it's a recurrent patient, and they have a few spots on PET, and it's probably not things you would see on a bone scan. I often treat those more like a biochemical recurrence because the older biochemical recurrence data, comes from conventional imaging. And one way I sometimes approach patients like that is treat them similar to the EMBARK trial for biochemical recurrence. So that was ADT alone, ADT Enza, or Enza alone. Yeah. Typically I'd give them the combination, but it also built into that trial, if they had a great response, they had built in a treatment break.
Yeah.
Yeah.
That was a very high risk population. Yeah. than equal maybe.
So got
PSMA
time.
PET, but those patients likely would have had very disseminated at least.
Yeah, so and it's a point paying. They're not,
disease.
very dissimilar or the same kind of patients as you would see on a low level of molecular imaging positive disease.
And that is one prognostic feature we haven't mentioned yet is PSA doubling time for recurrent patients. So there's like a great paper that I cite all the time with patients, like we're at Johns Hopkins, their culture was to observe. So they have like the natural history of a lot of these patients. I think at Michigan, we observe a lot as well too. So they found if the PSA doubling time, this is conventional imaging, was more than 9 months, the median time to metastatic disease on conventional imaging was over 13 years. And a lot of these patients are 70, 80, maybe even in their mid 80s. So by the time they develop metastatic disease for which our treatments improve survival, they may, be riding off into the sunset for other reasons. And so then we can spare them, we can really improve their quality of life by not subjecting them to ADT. So I do observe a lot. And PSA doubling time is critical, I think, for that decision. And then, Bob, we haven't even talked about like a patient like that who has a few PSMA PET positive sites. Do you do radiation, to avoid ADT actually, and kind of like knock the mole back down into its hole, as we often say.
So I guess the short answer is yes. But just back to the intact patient with some molecular only mets. I mean, Todd knows this from the new NCCN guidelines, but sort of adopting, you can sort of lean into the Stampede M0 criteria. So if you have a PSA of greater than 40 or T3, T4 disease or Gleason 8 to 10, 2 of 3 of those are the patients that are likely to benefit from intensification, sort of independent. Those also seem to be the patients with localized disease that have molecular only disease. And so I think by the NCCN endorsing Stampede into very high risk, that might standardize that. Because I can tell you in the state of Michigan, looking at some of the quality data, is that both based off of PET disease and also the very high risk, there's extraordinarily heterogeneity in treatment.
Oh, really?
In terms of who's getting intensified, who's not, who's getting treated, who's not. And then the same sort of heterogeneity is in the recurrent setting, like you said.
For the recurrent patient, give me a sec to just plug.
Yeah.
An important plug for the last year's AUA, SUO, Astro salvage therapy guidelines for prostate cancer, which really does cover this topic. I think, really nicely going through kind of the fact, the recommendation to consider PSMA PET in patients with biochemical recurrence, but a recommendation to use PSMA PET for somebody who's going to undergo salvage treatment. Yeah. Why? Because Empire 1 data showed a benefit to PET-directed salvage therapy. And so no, not every patient needs a PSMA PET necessarily, because not everybody needs salvage therapy as a candidate for salvage therapy. But if we are going to recommend salvage therapy, then PSMA PET is really important.
That's right.
Yeah. Any other comments about molecular metastatic disease? Clearly, maybe what's coming to mind is that maybe for PSMA PET, we need a low volume, high volume definition, to sort of help us stratify more in a conventional manner as well as for clinical trials, because really there is no clinical trial currently that has only included PSMA PET criteria.
But it's very complicated because for PET, it could be the max SUV, it could be the collective max SUV, the number of lesions. There's so many dimensions.
And also,
Illustrations, the reading.
Insult to injury or beauty for all of us as researchers is that the same set of complexity in the upfront diagnostic setting is the same thing when we're on clinical trials and you get a recurrence and you get imaging. What historically would have been a biochemical recurrence now all of a sudden becomes a metastasis. And so is that a molecular metastasis? And some of our surrogacy work and some of our sort of shorter-term outcomes predicting long-term survival is all based off of conventional imaging too. So I don't know, makes me smile because there's a lot still.
Yeah, a lot to learn. I think one more thing I would say about PSMA PETs is, I'm curious for what everyone else's thoughts too, is like, it's not a perfect test, even though that name is prostate-specific membrane antigen. So, and I teach the residents that come, internal medicine residents come to my clinic this too, is like, they're so used to FDG PETs, like for lymphoma or lung cancer, hot is bad. And the hotter it is, the worse disease it is. But for us, we don't really know that. In fact, you could theorize that if the tumor has a lot of PSMA is actually a less aggressive tumor because it's retained its, prostate specificity. And we see those bad, like, neuroendocrine or even just bad prostate cancers, low PSA producing, very aggressive, and they're PSMA PET negative. And then, so I think our kind of rule of thumb too is like, if it's just not adding up, like the PSA is 2, but you got like tons of disease, like that really warrants a biopsy. And so I think sometimes there's some nuance with that. We all have a case or two where the biopsy came back not prostate cancer. Like I had a guy who had HCC, on a liver lesion because his PSA was 2 and he was feeling totally fine. Yeah. So I think there's just a, caveat, I think, with PSMA PET certainly.
So I think we need to lead a group effort of looking at PSMA PET and trying to put those people into different prognostic groups.